Welcome to the Long Story Longer podcast.
I'm Dominic Maranoand. I prescribe meds.
And I'm Katie Brzozowski, and I provide psychotherapy.
Long Story Longer is a podcast about mental health and navigating medication, therapy, and whatever else we want to talk about.
We will discuss topics from each of our perspectives. We will try to keep it to 15 minutes.
But it will probably be longer. Hello and welcome to the Long Story Longer podcast. My name is Dominic Maranoand. I am a family and psychiatric mental health nurse practitioner. I own my own psychiatric practice and I have a doctorate in the nursing practice. I've been in healthcare for over 20 years and more recently into mental health.
Hey, I'm Katie Brzozowski and I'm a licensed clinical social worker and I have a doctorate in clinical social work and I own a private practice and I've been in the mental health profession for over 25 years.
So today we wanted to talk about finding the right mental health provider and spotting the ones that aren't necessarily a good fit if you already have one.
And what type of provider you might need.
Yeah, I think there's some confusion. Generally in mental health, we're trying to bridge the gaps between medication and therapy and even understanding that different providers provide different resources.
Mm-hmm.
So I prescribe medication, but I don't do therapy.
And I do therapy and I don't prescribe medication.
And there are some providers that actually do both. The first part is where to look for a provider. There's a lot of places where providers advertise. It depends if you're going to pay with cash or use your insurance. So some people advertise on various websites and some people use word of mouth. Really depends upon your situation. Typically speaking, if you're going to use insurance, your insurance has to have the provider within network. Some insurances offer out-of-network coverage if you meet certain cost requirements and things of that nature.
I suggest that people first, if you're going to use your insurance, call your insurance company. Ask if you have an out-of-network benefit because that's going to help as you look around for a therapist. If someone says that they take your insurance, but it turns out they're out-of-network, you'll know that if you have that. Find out, if they have a list of who's in network. Start there because it is good for you to understand your own benefits and what you have.
Yeah, I mean, I don't know about you, but it's also really taxing for the provider to call and figure out how much is it going to cost. I forget what the act is. It might be called Sunshine, but it states that no cost should be a surprise to a patient.
Is it the No Surprises Act?
It might be it's something.
Forget it, but
I don't know where Sunshine came from. It might be. I feel like there's multiple acts of different things, but it's basically a No Surprises Act for cost. So I like you said, recommend that people call their insurance. Sometimes there are navigators that help clients find providers. Knowing that you can do a Google search, knowing that you can use different websites. We're not going to name any specific ones. We certainly advertise on them, but you can go on the internet and find many if you just look for mental health providers or mental health medication providers, psychotherapists, therapists, just doing a search. The other thing is I do love word of mouth. I think we have people in our lives. Everyone has some degree of mental health concerns one way or another, and some people seek professional treatment for them. You may be a good fit. I have a bunch of clients where some of them are siblings, some of them are distant relatives. So when you find a good person that goes along with you, it might go along with birds of a feather flock together sort of situation where if you have similar experiences and issues and someone's equipped to handle them, it's not to say that they're going to be a definite fit, but using someone who someone else likes may be useful.
And the one caveat to that is if you're too close to that person, the therapist might not want to see both of you because it could be a conflict sometimes. Like if it's like the members of a couple, I might not see both of them because it can get tricky, but if it's far enough removed, then it's, and of course there's always exceptions, but if you ask somebody who's your therapist and they tell you, I don't want you to go to them, don't get offended because it might make sense.
Yeah. I think also too, even with, if you're looking for a marital counselor, they recommend that each of the couple see the marital counselor and then each see their own individual therapist. Yeah. You wouldn't have want the same person seeing the same people over and over again. It's overlapping and gets a little confusing. And also other sources offer different insights.
And for couples counseling, just an aside, if you are in couples counseling, the couple is the client. So it's very different when you have an individual. The individual is your client. So if you have an individual and then they bring their spouse in, the individual is still your client. You're just seeing them both. But really, for couples counseling, the couple is the client. They're not separate. So it's a different way able to.
Yeah, and I think that comes itself to what we were first talking about is just determining what provider you need, which is if you're looking for marital counseling or couples counseling, if you're looking for individual counseling, if you're looking for group therapy, if you're looking, there's a number of different places that, in terms of medication, it's usually one-on-one. I don't think there's really any group settings like that.
No, I'll get Lexapro.
But
I did a brand name, sorry.
There are certain specialists that handle certain medications. For instance, like an example would be long-acting injectables. If someone's on a medication that they get injected, certain people don't do that. Certain people don't do IV ketamine therapy. There's a number of different things of providers and prescribers where just knowing what you need. Sometimes you don't know what you need, so you can start off there, but your provider can tell you, "Hey, I'm able to do that," or "Hey, I can't do that. Maybe you should go elsewhere." Next would be what to look for in a provider. So there's a ton of different credentialing.
Yes, I was that we could do a whole episode on just that, but we probably should go over the
Yeah.
different
Yeah.
types
So
of
yes.
providers.
Yeah. So for medication, it's pretty easy. There are physician-based prescribers. These are your psychiatrists or your primary care providers. Primary care providers can do the initial prescription of medication, but when it gets complicated, I think we mentioned that before in another podcast. We're saying when it gets a little complicated, you're going to go to a specialist, someone who understands the medications. But primary care providers, which can consist of physicians, physician assistants, nurse practitioners, having the credentials, basically looking them up and determining I am a nurse practitioner. I do have my doctor, so it's a little confusing. So I think people will, I'll say, they'll say, oh, doctor. It's like, well, just want to let you know, you can call me that. In some states, laws vary. Some states you can't call a DNP a doctor because it's a big thing. But in Delaware, where I primarily practice, you say, hi, I'm Dr. Dominic Maranoand, psychiatric nurse practitioner. If you don't put that tail on there, you can get into trouble. But as long as you specify what you are with a doctorate. But yeah, physician assistant, a regular physician. And then people will have a slew of alphabet after their name. So in terms of medication, they just have to have the ability to prescribe. Um, and that's a little bit easier than probably your place because there's a ton of different psychotherapy providers.
I will go over those briefly. You have your clinical social workers, licensed clinical social workers, that's LCSW. If they're not fully licensed, they're LSW. That means they're under supervision of an LCSW. Then you have your, at least in New Jersey, because this is all state dependent. So in New Jersey, you have the LPC, your licensed professional counselor. And then the pre-licensed version of that is the LAC. And then you have marriage and family therapist, so LMFT. Then your licensed psychologist, and that can be either a PsyD or a PhD.
And I think there's also what gets a little confusing too is sometimes people are in training and being supervised, but basically knowing that someone should provide you with their credentials and what that enables them to do, or if they have any restrictions on their license that they're not able to provide specific care for you.
And you can ask them, are you currently fully clinically licensed or are you getting supervision for licensure? They're still under supervision, which is good, but also you want to make sure they are getting regular supervision and that they do know what they're doing because your mental health care is serious. So you want to make sure you know that you're in good hands.
Nurse practitioners in some states, you have a collaborative agreement with a psychiatrist. And again, they're depending on state law, it depends how often they meet up or refer out for things that are super, super complex. I run a solo practice, so I can handle certain things, but when they get to a level where someone may need additional support services or the complexity of their care is such that they need to be seen very frequently, I don't usually see people more than once a month unless I have to. And even that, it just lends itself to mental health medications take time. So that rapid adjustment, there's different tiers of outpatient teams. So you may need like a community-based provider and or a higher level acuity. But I'm just simplistically an outpatient mental health prescriber. So that's figuring out what you need initially and then working your way around navigating where to find them. So it's not the easiest thing in the world for sure.
It can be, yes, it can be very daunting.
Yeah. And typically speaking, I mean, I think there are even places that don't accept cash payers. Like you have to have insurance because they they don't want to get in the runaround of bill collecting, etc. So they'll do the copays, but they won't take. It's rare, but they do exist. And then
vice versa, people that don't take insurance.
And that was popular when COVID happened. There was a mass exodus to people to do telehealth and do cash only. There are pros and cons of that. Some of them offer concierge services. So these are services where you pay extra for concierge services, but they offer 24/7 coverage where if you call on the weekend, holiday, or whatever, they'll call you back as soon as possible. If they're sleeping, then when they wake up, the expectation is that they call you. Most places, most simplistic outpatient medication providers, if it's an emergency, you're going to call 911.
You are not on call.
Yeah. And then if it's an urgent issue, I think they'll usually say 48 to 72 hours with some urgency. It depends if they have a messaging service or whatever. But really, if that's something that you're looking for, doing your homework, like you said, going through the insurance companies is key because they should be able to provide you a list of providers. You can also go to the insurance websites and go on there and type in your plan and then see who's in network. Is it always accurate? No. And sometimes people drop different insurances. Like I know, for instance, I was with a company prior to going on my own, and they still have me listed with them under multiple insurance things. So I get these calls, and they're like, but it says your name's on there. Well, I'm not working for that company anymore.
Oh, I know in my practice, we are an outpatient clinic, and we do not see people that require a higher level of care, like intensive outpatient or inpatient.
Most simplistic outpatient practices handle basic mental health needs.
And they can refer you to all those other things. Your particular therapist should know to send you next if you need it.
Not every provider is the best fit for everyone. The last thing I want to mention about finding a provider, often providers will have consultations. You can call in for like 15 minutes or whatever, or sometimes it's shorter than that, just to feel if you do like a vibe check.
Do you do that?
Yes.
Okay, so this is a good thing to bring up because we don't do that. Tell me why I'll tell you why we don't do it, but you tell me you're doing it as a vibe check.
I do that, yes. And so I want to make sure that I can handle the needs, particularly with medication. Sometimes people come in and say, I need a stimulant. Well, I would say we evaluate you for them, or if they're looking for a specific therapy, like I don't do intranasal esketamine, that involves having clinical supervision, somebody watching your blood pressure. I know where to refer out, but I don't do that. So why would I evaluate you to have you need something else and go somewhere else? I think it's a waste of resources and time. And also, too, your practice is much bigger than mine. I'm kind of building a relationship with the community so people can call on and say, hey, I want to hear your voice. I want to hear how you sound, do a vibe check and take it from there. Most people I don't think I've ever had anyone who was like, no, I don't want to go with you. Or I think someone's insurance, they contacted me and said, oh, my insurance ran out and didn't want to do anything until it resumed. So I do like that 5-minute consultation, and then some people it's longer, like I said, 5 to 15 minutes. Where I advertise, I think we advertise in the same place. They say, will you do that?
Yes. They say, do you provide a consultation? And we used to, but the problem we ended up with is that the insurance verification process takes a long time. And if somebody is calling, do we verify everyone's insurance for a 15-minute consultation? No. But then we're going to waste our time doing 15-minute consultations because what if we don't accept their insurance? So it's like, so now if we accept your insurance, we have an intake person that will talk to you about your issue and they'll hook you up with the right therapist for your particular concerns. But we always just recommend you come in for the first session, you see how it goes. If it's not a good fit, it's not a good fit, but then you have the whole session to figure that out, and it makes it easier for everybody.
Yeah, and I think too, sometimes there may not be a formal like telephone call conversation, but there can be emails that are sent. And, and certainly like, on both of our pages, you can submit your insurance and say, hey, am I in network? So it's work, but it's your mental health. You need to put work into it to some degree. So I think that taking the time, and then there are some places that are able to do those consultations, other places that are not. And then once you still kind of do it anyway. Like if you call, you get everything set up,
yes. We don't do a formal 15-minute consultation, but it's still a consultation process.
Yeah, and it's not like a consultation where you're like, what past medications were you on? What past therapies did you do? It's like, what are you looking for?
Yeah.
And a lot of times you can get that from providers' websites, doing a vibe check that way. Speaking of vibe checks, there's also a vibe check that you can do for your current provider or
your future provider.
To see if your provider is a bad fit for you. So
Well, Dom, have you ever met anyone that said, like, I don't know if my therapy is working, or I don't know if my prescriber is doing a good job, and they don't know themselves, they're not sure.
yes, and I think part of it is that you share so much information with people that you feel a degree of loyalty to them.
Hmm.
But if the reality is that it's not making a difference, whether that be medication or psychotherapy, you may need to look elsewhere. And there are certain things to look out for. The first thing is just comfort, with feeling with how you feel. If you can't talk to someone after a couple sessions or after a couple medication appointments and you still don't feel comfortable conveying what you want to say to them, or they don't listen to you, or
Or you feel judged, or
yeah,
you
like
feel.
really just your degree of comfort is the first place. And I jumped ahead in saying that if they don't listen, that's a huge thing. So I mentioned before people, doing a screening where people say, I need this, or you're going to provide me this. I don't ever challenge anyone if they come to me and say, hey, I want to do this. I say, is it safe? Is it something that I feel comfortable doing in practice? Are there standards out there? And not everything is to the T to by the book, but I definitely will investigate something, see if it's feasible or if it's within my wheelhouse or comfort realm. So, but I personalized care is really the idea there is that you have to take input from your clients. You do.
Oh, absolutely. It's a collaborative process. And that's also back to finding the right person. You also want to make sure, at least for therapy, you want to make sure that your therapist treats the issues that you have, because not everybody can do everything. And so if someone doesn't see couples, not everybody can see couples. You have to be trained in that. Not everybody can see grief and loss. Not everybody can see substance use, right? So I think finding the person for you that's good at that, then, or that can address that, then when you meet with them, at least that part, you have to be comfortable with them. And actually, research does show that um, the most important factor in, or variable in, the outcome of therapy is the relationship between the client and the therapist.
So,
Success would be, for you, success is also measured in if the med is working.
well, yeah, and I mean, and but you have to determine like how even determining if is your therapy working for you.
Mhm.
Part of that comes into place of I use scales for just about everything. So if you have anxiety, whether it be a formal scale, or depression or sadness or whatever, or focus, I'll even do just a 0 being none, 10 being the worst or best, depending upon what the situation is, and then we use the same scale each time. So if someone's saying to me consistently, I'm 10 out of 10 anxiety, 10 out of
Mhm.
10 anxiety, that should be a red flag. Like
Nothing's what's happening.
something isn't working. If my thing is I'm just going to keep pressing what we're doing, then I might not be a good fit for you. I don't
Mhm.
usually do that, but the idea is that if they're not listening to you, if they're not looking at the data objectively that we can do with medicine, some people don't know how to describe how they're feeling.
Mhm.
They just getting it out there saying that, well, I'm not sure if the medication's working better or not. Well, I think I had said this before, but if your functionality, if your quality of life is better, then the medication may be doing something for that. So really just listening to your clients, and if they can't find the words to describe the situation with the medication, looking for externally, is it making a difference?
Yes, how is your relationship with your whoever? Is it better? Are you feeling like you can communicate better? So that would, like, from our perspective. For yours, it may be, are you just as tearful as you were before, or
Yeah.
more?
Most people were able to convey, hey, I took the medication, I noticed a change, regardless of what that may be good, bad, or worse. For those people who just don't have a clue how they feel, or if some people will say that they're numb, and well, is
Mhm.
that good or bad? For some people, it's okay to be numb and they want to be numb. That's part of their goals.
Mhm.
But most people aren't like that. But some people just want to turn down the emotions, and that's quite okay. Another part of comfort that we talked about was that they cross ethical lines. So if someone's not a good fit, they cross ethical lines. What does that mean? Making inappropriate comments, if they're having you go to a setting that's, I don't know, sketchy, or like, oh, just come over to my house for the appointment.
Yeah,
There are people
very.
who do that,
Yes.
and I think we talked about an example where in the LGBTQ community, it's a small world. And I
Mhm.
see a lot of LGBTQ patients. I see a lot of heterosexual patients too, but it's a small world. And sometimes if those worlds blur, your professionality has to supersede your social life or anything along
Mhm.
those lines. You shouldn't be talking about things, but you find that it happens sometimes. So that's a little scary. So that your mental health is very protected and should be, and you should certainly be following those guidelines. People practice however they want to practice, but they should certainly be respecting
the ethics, and all of our professions are guided by professional standards and ethics. I know for social work, we have our code of ethics, which is, the last I checked was like 132 codes, but I think it may have changed since the last time I looked. But it's very specific. Like, you can't have a dual relationship. You can't barter for services. This is one of my favorite ones. Unless you live in a place where that's normal. So if it's normal to give a chicken for something, then you can do that. But like in our practice, we don't accept chickens for services.
Well, that's, yeah. I mean, I think that it's not a quid pro quo situation. Some ethical things, I don't ever give my personal number to anyone. I have just our a
Hmm.
work number, and then that way it's separate. You can keep your personal life separate. I think when those lines blur, that is an ethical concern. Some people actually, I know providers who their work number is their own number and everything, but I like to keep it separate just because it's a way of delineating for me. Like, is this something that can wait, or is this my mom calling and I need to?
Yes.
So yes, mommy, I need to talk to you. Versus if it's a client. So
I made that mistake when I started. I used my cell phone number as my practice number, and now only my old
yeah.
clients have my personal number.
Yeah,
New
well, I mean,
people, they
you
don't.
do what you have to do. I mean, I think times are different now, and earlier on, that was the expectation. Because again, a bunch of people I trained with, that's they only have the one number.
Hmm.
Even on my side hustle, working in the hospital, there are people who give their patients their number and say call anytime. That's not ethical. It's just not where I want my work life boundary.
Right,
Yeah.
right. And mental health, our standards are a little bit different as far as what we can and can't do, because we can't be friends with our clients. You ever meet anybody and they're like, "Oh, I wish I could be friends with my therapist," or a therapist saying, "I wish I could be friends with my client." Some people, I mean, we're going to meet people in our regular life that we like and we don't like, just so then we'll meet people in this role that we like and that we don't like. So it is tempting to want to be friends with them, but that's just, or want to date them, but it's not allowed. And it makes sense because it's a professional role and you can really feel like you get along really great and you probably really like them, but it changes the relationship.
Yeah, I think it's more or less you don't have the relationship be one where any external factors can influence your ability to practice. So, and that's where you have a relationship, and that the provider client relationship, that's it. Other things aren't going to impact how care is provided. The last thing is that if a provider doesn't know their stuff, if somebody makes up their own guidelines to care that aren't evidence based, or if someone's prescribing you the wrong medication and just saying, oh, well, you should just try this, try a beta blocker for depression. Well, that's going to worsen depression.
Yeah.
Potentially. So just various things, like if someone should keep up to date, keep their license and credentialing up to date. And I think I mentioned before the services that I don't provide, I feel really comfortable sending out. And
Mhm.
and if you're not an expert in certain things that you see are clearly one of your client's diagnoses,
You should refer them
and
out.
you should feel comfortable doing that. It can be difficult if you have a working relationship with them, but that's part of your ethical code is to say, hey, I'm going to send out when there's something I can't handle. You don't want your mental health stuff to just to be on the fly and to have it with someone who doesn't
Winging it.
know what they're doing, or again, or wing it, or just, I think, provide a quick answer and not take your input, and it doesn't see the whole picture. So they don't know their stuff and they don't know how to engage with that. So is it easy to spot all of these? Not necessarily. Some people are really good used car salespeople.
Yeah.
So they will, hey, let's do this, and then I'll come over for dinner. Well, that's crossing a line. Or hey, let's do this wrong approach and see if it works. Or hey, let's use this therapy for something that it's not exactly applicable to. I think like group therapy for very personal things isn't always the best approach, particularly with people who have trauma and things of that nature. I think the appropriate applications and appropriate uses, you see that you'll get a feel for someone after a while. Some people can be very shady about it, but some people just, if everything doesn't add up, if it doesn't make sense, then that can give you an indicator that they don't know their stuff.
And for therapists, I try to make it clear from the very beginning when I meet with someone that I hope that it will work, or that this could be a good fit, but it might not be. And if it's not, that I do not take it personally, that it's whatever works for you. So if you don't feel like for whatever reason we're on the same page, I am perfectly fine with that. Don't give up on therapy or any type of mental health care just because that provider didn't work for you. I see that a lot, that people are like, oh, therapy's not for me. No, 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 no. The right therapist will help you, but and the right provider will help you. But it is just a matter of making sure that you have the right one. So if you're seeing a therapist for 6 months or years and you don't feel like your life outside of therapy is any better or your mood is any better, then it might be time to consider that you need a different one. I know that I was seeing my therapist for 9 years and he was great for all of it except towards the end. And when one day I just remember thinking I was having a hard time and I thought, you really should go talk to somebody. I said this to myself. And then I'm like, I see somebody every week. And then shortly thereafter, I found a new therapist.
Yeah. And with that in mind, the mental health prescribers, it's the same boat. Everyone has a different approach in doing things. So you may need a different perspective on things. Some providers are just very anti-benzodiazepine. They have their
What's
policies.
a benzo?
Benzodiazepine is like a Xanax or a Valium or an Ativan, or if you're watching TV, a lorazepam. Those are medications that are pretty addictive. So some people don't want to deal with the difficulties of having people on them, and the medication just going up and up and up. People becoming people becoming addicted to the medication and having to deal with that. There's also data that supports that those medications are not the best for chronic management. Actually, I knew someone who was looking up for a provider specifically to continue benzos, ended up landing into a place that was a no benzo clinic, and they switched into a medication, and he's doing phenomenally. And I asked him, are you feeling good on the medication? And yeah, feeling great. It was the best decision I made. Now I don't have to worry about getting my scripts filled. Even getting care outside of where you normally are, that can be a challenge if you're on certain medications or getting things done that aren't to protocol, because people will say, hey, that's not normally how we do things.
And if you have a therapist also, if you're on medication and you have a therapist, your therapist hopefully should have like, I don't prescribe, but I have a working knowledge of these medications, and I should, because if someone's telling me they're taking, Ativan every single day and they're not on any other mental health medication or psychotropic medications, I may question them and say, maybe you should try something that's a longer acting, that's not going to be like, okay, you take it, you feel better, and now the next day you're back to where you were.
Yeah, I think that's a good point. And it's also, we as medication prescribers will have ideas of the basic therapies that are out there, the cognitive behavioral therapies, the ACT therapies, and DBT, a number of different therapies that are used for a number of different modalities. So we all have the questions on the boards. We may not practice them, but we may know what's applicable. And you should know that. It's the final point of people should know their stuff. And if you want to find another provider, don't ghost your provider. Just tell them, end the relationship nicely and say, hey, I'm going to see somebody else. It's, if it was a bad exchange, maybe that's a different story where you both got into a fight or something along those lines. But I haven't had it happen many times. But the times that I did have it, I took it personally, because I was like, wait a tick. I tend to go out of my way for people who write emails, and I don't charge for paperwork like a lot of places do. I try to give nuanced care that's a little more caring and goes above and beyond the expectation. But when I get ghosted, I take it personally. And maybe I'll get a thicker skin later on. But it's okay to say to your provider, hey, I think I need a different medication provider, a new set of eyes on things. I would appreciate that, respect that so much professionally. And the other thing is that it is a small community. People know that you went elsewhere. Or if like, wow, their meds haven't been filled for some time, and you're like, oh, well, that either they've gone to someone else, or they fell off the planet, or they're off medications. That could be disastrous in and of itself.
And for continuity of care, because if your client wants to switch, you can help with that and talk to the other.
I've had people move, and obviously that's not like a ghosting, but they're moving, and take your records with you. You have every right to have them. And that's if we end our relationship amicably and know that I'm not perfect. I'm not going to be the perfect fit for everyone, and my approaches may not align with what your goals of care are. That I've also said to people that they need to go and see someone else and hear your medical records and go and take them, because it makes the process of switching so much better when you have the records from before, because you can see what didn't work, what did work before, and any concerns. I always take medical records, I look over them, but I'm my own set of eyes and ears. I will process that on my own.
That I think it is really important that we look at the client from our own perspective, because I don't like to take someone else's diagnosis. So if they're coming from a physician or they're coming from another therapist and they say, "Hey, I have bipolar disorder." Okay, well, I'm going to assess that myself, because I want to make that my license is on the line. If I just say, "Okay, bipolar disorder," and I put that in your chart, I'm saying that's what you have, but I don't know that because I haven't assessed. So I will provide my own diagnosis, and it may not match your previous provider.
Yeah, or how many times have you gotten a new client and they have like 47 diagnoses? And there is we talked about this before, a lot of overlap in mental health, but you like can't have everything in the DSM-5. Like, you can't have everything. It's just it doesn't make sense. So I do try to tidy up diagnoses, or it can change too. For instance, not some people grow out of ADHD and they don't have it any, but they could still have other mental health things, or depression. You can have a bout of depression and it can be in remission. That doesn't mean you have it and it's active. It's in remission. So the diagnosis can change, and then I think some people are aware of that, and but most importantly, every provider does their own evaluation. You can confirm the diagnosis by their own evaluation, but certainly takes that into consideration. That start off with a blank slate. Understanding why things haven't worked is, I always ask allergies, because some people are like, I am allergic to Prozac. Well, what happens when you take Prozac? I have diarrhea. Well, that's not allergy. And so that doesn't mean it's off the table. And did you have diarrhea because it was something you ate? And so I really like to dive into how a medication didn't work too, if we've been through a myriad of things, or go into psychotropic genetic testing. Some people believe in it, some people don't. I like it. So that may differentiate me from other providers, and be a place that if it's something you want to look into, then we can do it.
Well, in summary, I think we talked a lot about how would you find your mental health provider, and then once you have them, are they a good fit, and how do you know? And if they're unethical, or if they're doing something wrong, that's a separate issue, and that's something that you definitely want to be aware of. But the majority of it is really, it's just that it might not be a good fit. It's not that they're a bad provider.
Yeah,
it's just that
it might not be good. You may have outgrown them. The situations may have changed in life, where you don't need someone for one thing. Say, for instance, you went for therapy for one issue, and now you need therapy for another issue. And that's not that person's area of specialty. Yep. So if someone's not trauma based and you now have a traumatic experience, you can't stay with the same person if they don't know how to do it. And you don't want them to fake it till they make it, particularly with your mental health.
Absolutely not. Actually, is a good point, because I used to be an oncology social worker. And so in my private practice, I see a lot of oncology patients. And I will see people that had a different therapist, but once they had a cancer diagnosis, that therapist wasn't trained or able to help them with that. So then they will come to me because I have that area of expertise. And then the same if I have a client and then they have some other issue that I don't have any experience with, then I may refer them out to someone else.
Yeah, I think a good provider knows their limits, and you don't want to I don't like to use patients as their clients as guinea pigs. I'd rather have them go to the appropriate provider. I think you mentioned it before. You wouldn't go to a gynecologist for a heart issue. You would go to someone who's specialized in a particular area. I don't think you used that example.
I didn't, but
it is stuck in my head. So anyway,
that one's better. That will stick in people's heads more.
Yeah. So that just means that they're a therapist isn't a stamp all, see all. A medication provider has different areas of expertise.
So if anybody has questions or comments, we are definitely open to discussing this further.
And yes, and it's not just about finding a provider or making the change of your provider if they're not a good fit currently for you, or if you outgrow them or whatever. But if you have any questions about anything, I would love to at some point just have a question.
Q&A.
Yeah, Q&A day.
Yes.
I would love that, and where we could take that, and if people want to record their questions, that would be great. We could add them into the podcast, or we could just read names and things like that. We'll see where it goes. But however you want to do it. Yeah. Well, then we can cut some of this shit out if we don't. I mean, this is brainstorming. I meant to talk about that earlier. Anyway, so.
Well, long story longer.
Long story longer, we probably went pretty long on this one. So we always look at the timing, and we're up to well past 15 minutes. Editing will cut a lot of this down, but.
Well, it was an artificial restraint anyway.
Right. Yeah, we'll see where we land. Again, we're learning with this too, and hopefully you get something fun out of it. Hopefully, you find good providers, and if you haven't, you know how to change it now.
Yep.
So I am Dominic Maranoand.
And I am Katie Brzozowski.
And we're with Long Story Longer, and have a good day. Get a good provider.